capitalizing on a stellar lineup of experts from Singapore, Malaysia, and Cambodia to tackle the role of multimodality imaging in patients with big and bulky hearts, or the so-called cardiomyopathies. So, dear guests and friends tuning in virtually, please get your cup of coffee and enjoy the exciting dialogues tonight.
Thank you, Dr. Mano. At first, I'd like to introduce Dr. Huai for your first talk.
Thank you very much for the kind introduction. I would like to speak about cardiac amyloidosis. This is a case study. I have no disclosure. My patient is a gentleman who is 62 years old, and his BP is 90 over 60, and heart rate about 80, and his oxygen saturation is 97%. He has no chest pain, but he has dyspnea with functional class knee heart 3. He has jugular venous distension with normal heart sound, no murmur. His lung sound so decreased air entry at the base of the both sides. He has mild bilateral edema at lower legs. He has left side hemiplegia, and he has elevated natriuretic peptide and troponin. He has a history of cerebral infarction. With the CT scan seen 4 months ago before the admission. This is the ECG. We can see that the standard leads show the low voltage QRS, and the V1 and V2, we can see the QS, but his coronary angiogram was completely normal. And this is echocardiogram. You can appreciate that this is a longitudinal parasternal longitudinal view and the soft axis view. We can see that the ventricular one moderately thickened, and we can appreciate the sparkling echo, and we can measure the septum and the posterior one. We can, and this is the moderate thickening, and also we investigate the right ventricle, and we can see that we can see that he has the thickening one of the RV measuring 12 millimeters with the M mode at subcostal view, and he also had the atrial septum thickening. Also, we can appreciate the mildly thickening of the tricuspid and mitral valve with the mild regurgitation and the mild regurgitation of the aortic valve, and the TR is the mild to moderate. The ejection fraction is on 2D echo is 30% B-plan with Simpson method, and with and is the 34% with 3D echocardiography. This is the Doppler investigation, and this is the mitral inflow, and you can appreciate that the E velocity is very high and the A velocity is very, very low. So the EA ratio is 5.5, and he has the shortening deceleration time, and he has very low E prime at both septum and lateral. So EE prime is 33. And he also has borderline isovolumic relaxation time, and he has the TR velocity more than 2.8. We tried to collect the pulmonary vein flow, but we couldn't obtain the atrial reversion flow. Maybe his atrial contractile is very poor. He has the enlarged left atrium with the volume 80 millimeter on 2D, and this is on 3D. This is a very large left atrium. And this is the mitral inflow and tricuspid inflow during the the respiration, and we can see that the change with respiration is only 10% with mitral inflow and less than 10% with tricuspid inflow. And he has very dilated IVC measuring 24, and with inspiration you can see the systolic inflow reversion, showing that he has restrictive physiology. And it is a spectrum tracking, and on the ventricle would track very well, and he has the apical sparing pattern, and the GNS is about 7%. And we also calculate the ratio of the average apical strain and the sum of the average, basal, and mid strain, and the ratio relapse is 1.5, so it's greater than 1. So we suspect that he had the cardiac amyloidosis because of his prior brain infarction. So we do the TEE to search for the thrombus, and we see the very small thrombi in the left appendage atrium. And the left atrium strain is very poor, and you can see that all three components is very low, especially the reservoir strain is only 2%. So the relaxation function of the atrium is almost gone, and the contractile function is doing very little. Similar on the two-chamber view. This is a the two-chamber view and the four-chamber view of the left atrium strain. So the very poor properties of the left atrium function. The RV function is very depressed as well. You can appreciate that the top C is about 10, and the S prime is 9 centimeters per second, and the FAC is only 19%. Especially the strain imaging of the RV is very, very poor. The GNS of the strain of the RV is only reduced markedly, and the TAPSE seen on the with AI is only 8. The RV ejection fraction is only 25%, so it's very far below the normal range, about 45%. So I have two questions for the panelists. The first, when should we do strain? Is there any specific wound thickness where we should consider? The second question, how specific is apical sparing cherry on top? How do you use that in your practice? Thank you.
Okay, thank you, Dr. Hoài. May I ask on panelists, Dr. Linh, what do you think?
Yes, maybe I'll answer the second one. How specific is the apical sparing cherry on top? And of course, when this phenomenon was first reported, I believe by investigators from Cleveland, the sensitivity and specificity of this finding seems to be quite high. But as more and more studies are being done and more cases in clinical practice are being encountered, we are finding that this cherry on top appearance is not that as specific as it was taught for the sort of like the specific diagnosis of cardiac amyloid, and can occur in some various other conditions, including in people with hypertensive heart disease, in people with aortic stenosis. But it would not really be so surprising because when we've looked at echoes for many years, and typically when we appreciate the wall motion in these patients with cardiomyopathies, we generally see that in many cases, the apical function is much better than the mid and basal function. And so, this is like the complete op process. What this process is, you have to interpret it to some extent in your patient, but it still also, it also highlights the potential that this is amyloid, and therefore, we need to consider this diagnosis in our patients whenever we see this pattern.
Thank you, Lin. And Barakat, what do you think about the first question?
So when
we do strain?
When should we do strain? I mean, if you are seeing a left ventricular hypertrophy, I think you should do strain in all patients with left ventricular hypertrophy. It doesn't mean that all of them are going to be amyloidosis. It doesn't mean that all of them are going to be restrictive cardiomyopathy. But even in hypertensive patients, in aortic stenosis patients, the presence of reduced strain can prognosticate this group of patients. That means you can use it for prognosis purposes and also for diagnostic purposes. So I think to me, if you see a thick wall, I think it is a must for us to do a strain. And when you do a lot of these strains, it becomes a practice, and you will never miss a restrictive cardiomyopathy in the future because it gives you clues. As for the second question about apical sparing, I think Ling has already explained thoroughly regarding the specificity. I think when we look at the apical sparing, we have to look at the whole general picture of the echo study. If you have RVH, LVH, on top of that, you have apical sparing, then it's unlikely, in the setting of aortic stenosis, in the setting of, a hypertensive heart disease, unlikely you have RVH, isn't it? So you have to look at the overall picture. When you don't only look at the strain, but you also look at other things in the echo. The presence of pericardial effusion, the presence of pleural effusion. On top of that, there's LVH, there's apical sparing. And you showed clearly the left atrial strain, which was extremely reduced, which you do not find in other conditions. So I think you have to look at it as a whole and not only as one entity in the echo study. The other thing is when you have apical sparing, this gives us a reason. Whenever I teach my fellows, when you see apical sparing, yes, it could be something else, but it gives us a stronger reason for us to do a cardiac MRI. Because I think when you do a cardiac MRI, then you can actually differentiate between all these other differentials that we are dealing with.
Okay, thank you, Barakat. What do you think, Dr. Hoài? Do you agree with the answer?
Yes, thank you very much for the wonderful point and discussion. I totally I appreciate your your expertise, the expertise that you share. May I move forward to the CMR? For the CMR, we do the cardiac CMR with the 1.5 Tesla, and you can appreciate that the wall of the ventricle, left ventricle and the right ventricle is thickened on 2-chamber view and 4-chamber view, and you can also see the left gadolinium enhancement can be seen. It can be seen on the ventricle wall, on the right ventricle wall, on the left ventricle wall, and even on the left atrial wall. And especially we see that they can be seen in endocardium, and we calculate the ECV. It is 60%, and with native T1 mapping 1200. So it's very suggestive for cardiac amyloidosis. So, and we do the amino fixation, and it shows that the patient has a very high kappa light chains, and the kappa to lambda ratio is very high as well. And he has the nephrotic syndrome with the 24-hour proteinuria 3.5 gram, and we did the bone marrow biopsy. It shows the clonal plasma cell 8%, and it shows some immunophenotype. And we also did the fat pad biopsy, and because of the nephrotic syndrome, we also did the renal biopsy, and both of them confirm amyloid deposition. So given the patient is very weak and the very low ejection fraction and prior cerebral infarction, so we didn't move forward to the stem cell therapy, and we give them the Cybody treatment with cyclophosphamide, bortezomib, and dexamethasone, and heart failure treatment. And also we give them NOAC with rivaroxaban. And this is a pre-treatment strain, and the ejection fraction is 30%, and he tolerates when with 2 cycles, and after 2 cycles, the strain imaging, so the improvement and the ejection fraction improved to 39%. So we have one question that I hope you will have to explain later. Should we give a prophylactic anticoagulation when the atrial contractile function is severely depressed, even when there is no documented atrial fibrillation in patients with AN amyloid? And the key points of my presentation is echocardiography led to a rapid diagnosis of cardiac amyloidosis, and strain should be a standard of care in case of NVH, especially when there is RV thickening one as well. Multimodality imaging, especially CMR, plays important role in the diagnosis workup of cardiac amyloidosis. In patients with cardiac amyloidosis, cardiac embolism can occur when atrial contractile function is very poor, even there is no documented atrial fibrillation. Thank you very much, and I hope we can continue the discussion.
Excellent, guys, Dr. Hoài. Okay, we continue for discussion. What do you think about this case, Danny? You will give anticoagulant in this case?
Hi. I think very interesting presentations by Hoài. I would like to give the floor to our other panelists to share their insights, like Dr. Lim, maybe.
All right, yes, thank you. As Dr. Hao already mentioned in this case study that the patient has ischemic stroke, yeah, right?
Yeah.
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 That's right. That's right.
Yeah, yeah. He has in his past medical history, he has an ischemic stroke.
Yeah.
So I think we can explain that because of poor atrial contraction, it can cause thrombosis. And so for this patient, I think prophylactic anticoagulation must be useful for him for prevention for ischemic stroke. Yeah.
Thank you.
Yeah.
Okay, Dr. Hoài, what do you think about the prognosis of this patient?
Yeah, I think his prognosis is at the baseline is very poor based on Mayo criteria, on other criteria, and he has a cardiac the amyloid deposit in the heart, and also in other organs like kidney, and he's have a depressed function of both RV and NV, and especially the left atrium, which can so it can occur, the AFib can occur at any time. So there's so many, so the risk profile is very high. So I think this patient has very poor prognosis, especially he has light chain amyloidosis.
Yeah. Here we have a colleague. She had many experience in cardiac amyloidosis. I would like to ask Dr. Minh Thư. What do you think about this case?
Yes. The patient, firstly, the patient has a thrombosis in left atrium, in other left atrium. In addition, I see in the result of the biopsy, bone marrow biopsy, it shows CD 138 positive. It may be the patient have.
Yeah.
We can see Endoclonal plasma cell, just 8%, under 10%. But immunophenotype CD138 positive. It means that the patient have multiple myeloma. In multiple myeloma, we have to be try anticoagulant for prevention thrombus. In addition, we can calculate corona score to calculate the patient have the high risk or low risk for thrombus. In conclusion, in this patient, I agree with Dr. Hoài to prescribe coagulant for this patient.
Okay, Nani, maybe we have a question from the audience. That's right. Can you show it?
Yes, there's a question in the Q&A box.
Yeah.
And audience member is asking how much the
Show it.
cycles of treatment costs.
Thank you very much for the question. Because the patient has the medical insurance, so the insurance cover the treatment expense, so the patient do not have to pay. But the medication is very expensive.
Can I ask Professor Hui? Well, in this case, I think it's because of the history of stroke. I think everyone would agree that in the setting of reduced atrial strain and, even though you don't see a thrombus, you will anticoagulate because the source probably is from the left atrium itself. What if you get a young patient who had never had a stroke and has been diagnosed to have newly diagnosed amyloidosis and with a very reduced left atrial strain? In this kind of situation, would you anticoagulate this patient?
That's right. Very good question. What do you think in this case, Dr. Hoài?
He asked Dr. Thư, maybe.
Okay, Thư, we will give anticoagulant. Can you answer, Thư?
Thầy hỏi lại giùm con.
No. In person with poor atrial function, we do not the history of ischemic stroke. When we cannot see the thrombus in the left atrium or left atrial appendage, but very poor atrial function, do we need to give anticoagulant?
As we see in the case, maybe the patient have multi-myeloma, so we have indication for anticoagulant for prevention thrombus. Although the patient has no the AF. Yes, we do not interesting in the ejection fraction of atrial.
But if the person have no sign of multiple myeloma, but only very poor atrial contractile function, do you give anticoagulant?
Yeah,
if the patient has no the diagnosis of multiple myeloma, at that time we calculate the corona score to decide the patient high risk or low risk to decide prescribe coagulant for the patient.
Yeah, may I have a comment? I think that if the patient have a very poor atrial function and he has the AL amyloid, so the risk of the cardiac embolism is very high. And even when he or she has a thrombus in the atrium or left atrium, appendage atrium, and we use anticoagulant, but with time, the thrombus is still there and they do not go away. So my point of view is, my opinion is, we should coagulate the patient with very poor atrial function, especially with the light chains amyloid. Thank you.
Okay, we have still have only 2 minutes. Any question from the panelists or audience?
Just a point about just a point about the atrial function. 2 points. First is that this atrial dysfunction, I presume, could either be due to amyloid infiltration into the left atrium. Yeah. I guess this has to be the case because it seems the presence of left atrial amyloid is in fact an early manifestation in cardiac amyloidosis. And of course, it also could be due to the diastolic dysfunction related to left ventricular infiltration of amyloid as well. But this is just for incredibly low left atrial strain, which is really very, very spectacular in this patient. The second point is, we always talk about atrial septal thickening in cardiac amyloid. What does that mean? How do you know that the atrial septum is thickened? Is there a number that you use to denote atrial septal thickening?
Thank you very much for your very important question, a very practical question. I think when I evaluate the atrium septum, when I see that there's no dropout of the middle part of the atrium septum, like when we see in normal patient, we suspected. Second, I compare the thickness of the atrium septum to the valve and to the ventricle septum and the echogen of the atrium septum. We compare it to the echogen of the ventricle septum, and in amyloid patient, the echogen is very similar. In comparison between the atrium septum and the ventricle septum.
So we don't need the number of measurement, Dr. White.
I just do my eye evaluation. I do not measure.
I don't know.
Yeah.
Okay, I think that no more time. Thank you very much, Dr. White. Excellent case. So now you would like to introduce Dr. Minh Thuy for the case. I think it's very interesting one. Dr. Thuy, please.
Yes, good evening, professors and all of my colleagues. I'm Dr. Thuy from Ho Chi Minh City, Vietnam. And today I joined Asian Echo Dialogue with a topic about the pediatric dilated cardiomyopathy. And about the disclosure, I have many conflicts of interest. Heading to my case, this is a 2-month-old Vietnamese girl, and she is the second child in the family with 2 children, lower segment cesarean section delivery due to the prior C-scar. She is full term. Her birth weight is 3.2 kilogram and discharged 3 days after birth. About the family history, without history of heart disease, and the father is quite normal up to the date they met us. And the patient with the mother, no history of diabetes in pregnancy. My patient 3 weeks after birth, she started with dry cough, tachypnea, and taking longer to feed and jaundice. She was hospitalization in local pediatric hospital and noted the low EF function and suspected the atrial tachycardia. At that time, they're using the amiodarone and diuretics for her. After 2 weeks, she was discharged and checking up at our hospital at that time. And I saw this baby at 2 months of age, 3.8 kilo with levocardia, and the ECG showed the sign of rhythm intermediate deviation, and the heart rate at that time is 160 beats per minute. She have got the criteria for LV enlargement compared with her age, 2 months. And the echocardiography we done in our hospital at that time showed the dilated LV and systolic dysfunction, severe dysfunction, with pulmonary hypertension and no structural heart disease, just only the small ASD we noted there. And I will show you some image about the echocardiography at the first time we met her. Here, in the long axis view, you can see dilated LV and without LV OT obstruction. Short axis view, again, we can see also hypokinesis of all of LV wall. In the TM, we can see the LV dimension is 33 mm, and the Z-score we call by Detroit is plus 5.4. I know that recently ASE guidelines, they don't mention about the TMEF and focus on the LVEF by 2D, but I still use it in my pediatric patient due to the Z-score of LV. Conclude the integrate software in a GE system to make it easily to diagnose and follow up. Although there are many G-scores for body surface area, for age, for gender, such as Detroit or Boston or the others. But in practicing, as I mentioned before, I choose Detroit and as the primary diagnosis. If any confused, I will recheck by the others Z-score. And with this view, we can see the low LVEF in Simpson. The biplanes is 16%, and for chamber, 2 chambers is 20 and 12%. I also apply to evaluate the function of this baby by the strain. The GOS is minus 4.8% at the first time, and compare with her age, it's severe systolic dysfunction. And with this patient, firstly, I try to use the myocardial work. Recently, we have got some evidence for the myocardial works in some disease such as the dilated cardiomyopathy. Also in the baby, I show here after count from the GOS and the brachial BP, we can see here is the low work efficiency. It's just 69% and high work waste, 189 mm of mercury. And also the other function is the diastolic function. I try to evaluate in this baby due to the E over 8 and E over E prime. The LV volume index is also high. And here in the pediatric with the dilated LV, I also exclude some congenital heart disease. We can see with this view, the color, and also we can see the dilated of the PA and mild to moderate pulmonary regurgitation with the pulmonary mean pressure is quite very high, 36 mm of mercury. Without the PDA, we can see in this view. And here, also again, we can check the valvular disease with the mild to moderate tricuspid and mitral valve regurgitation. In this view, I show you just the small ASD with left duration. And the next one, again, we can see the dilated PA without PDA. Due to some other cause of the low LV function, I find out the correct position and normal size of coronary artery. The patient without coarctation. So at the first time I saw this patient, the symptom of heart failure, class 3 in the moderate gross classification and severe LV dysfunction in many methods, dilated left chambers and no structure or congenital heart disease, moderate MR, mild to moderate TR, and pulmonary hypertension. So at first, I'm thinking that is idiopathic dilated cardiomyopathy. For discussion, as you know, as same as the adult, dilated cardiomyopathy most common, but we need to remember the hallmarks and exclude the other cause of dilated of LV and systolic function. Remember, in the children, we need to use the Z-score, as I mentioned. If Z-score of the LV is more than +2, and systolic dysfunction if the Z-score less than -2, and absent of the hemodynamic causes. That's the reason why we need to check the coronary artery and the aorta abnormality and others congenital heart disease when we do the echocardiography in the pediatric with the dilated LV and low EF function. And other lab tests, we also make to exclude some other causes like the metabolic anemia, in this case normal. And in the pediatric one, one thing besides the echocardiography we need to remember is the genetic testing. And in this baby, we can see two mutated genes in this baby, NEXN and MYH7. All is the autosomal dominant and the phenotype of the dilated cardiomyopathy. Hit into the result from the father and the mother, we can see here they alternately have an abnormal gene of the baby, and father got the clinical manifestation. I also do the exercise echocardiography for him and with a negative result, and the others in the mother is quite normal. So with the result from this patient, maybe it's the abnormal combination of genes cause make my baby got the very severe symptom from the infancy. So sorry that so far I have no the result from her sister genetic testing. And after 4 months, from 2 months old so far, she's slowly improving in the heart failure symptom on treatment, LV dysfunction, and at that time with the genetic result, I decided to diagnose this patient with genetic dilated cardiomyopathy. And also the echocardiography, not only the tools for us to make the primary diagnosis, also in the disease progressing, echocardiography will help us to follow up the patient. Again, we can see, again, my patient after treatment at 6 months old, she has got still dilated LV, LA, and the LV function improved, but slowly and a little bit. LVEF so far by TechCon is 30%, by the Simpson is around 20%. And the GOS, the myocardial work, I applied to try to follow up and make comparison is increased, not too much, but it's increased slowly. And my TR, moderate MR, and pulmonary pressure is lower. So my case, I think the pediatric dilated cardiomyopathies are also the challenging to us, but the Z-score is useful in diagnosis cardiomyopathy, especially the dilated cardiomyopathy, and is the tool for us in follow-up. We need to rule out some congenital heart disease, especially aortic coarctation, coronary artery disease like ANCABA, and the new technique is not only the tool for the initial diagnosis and also the good tool for long-term monitoring. And I stop my case here, and I hope to get some questions and also teaching from my professors. Thank you.
Okay, thank Dr. Thuy. Very interesting case. I have question. Any idea from panelists? I see Dr. Lim here. Welcome, Dr. Lim.
Oh, yes, thank you. It's a great talk. I have one question. So, are there any specific echo parameter associated with a more favorable or unfavorable prognosis in this newborn with genetic dilated cardiomyopathy?
Dr. Thuy, can you answer?
Yes. Thank you for your questions. So far, we have got many war of the Z-score in the pediatric one, and it belongs to the population they mentioned. Like before, we use the Detroit as the very easy, and I think it's one of the first Z-score for diagnosis the structures in the pediatric one. But recent years, the Boston G-score also apply for the baby. As I mentioned before, why I use the Detroit in the diagnosis in this case, and I mentioned about this because with the it's also the integrated software conclude in the GE system, one of the system of echocardiography that I use in my hospital and the other hospital, I think. So when we started to do for the pediatric one, maybe the neonate or the infant, we need to use it at the initial tools for exclude or the diagnosis, the structures, and it's not take a long time for us. In case of I saw here, it's very clear, but in some case of the borderline, we can check by the other system, Boston or the other, to make the first diagnosis, and after that we will confirm it by the others.
Another panelist, Dr. Ling, you have any comment?
Yeah, obviously not a pediatric cardiologist, but I would be interested to know, obviously this is such a young patient. When you have a ventricle that is this poor in adults, we always think of, ICD implantation, but at what age do these, at what age does the consideration of an ICD surface? Would it be sort of when patients are in their teens? When this is a consideration?
When còn chưa nghe rõ lắm á thầy, nó bị mất.
Dr. Ling, can you repeat the question?
Oh, okay, yes. When we see adults with dilated cardiomyopathy, with EF of less than 35% and ICD is one of the things at the back of our mind. Now, obviously, this patient is such a young patient, but I would be interested to know in pediatric patients, at what age do we ever think about sort of implanting an ICD? Would they have to be miniature adults before we think about this?
Yes, I know, but at the age of my patients so far, I have no any experience when using the CRT or the ICD for her, but I also check up follow up to the guidelines for pediatric one, and maybe in some next month I will make the discussion with the specialist for how can we use the CRT or ICD support to the patient with dilated cardiomyopathy. So far, she's really small, just 5 kilograms.
Yeah.
Yes, and it's one of the very difficult to catch to any device.
Yes, right. Yeah, obviously not a consideration at this stage, but
yeah,
definitely later. I also had a question about, you know, the use of myocardial work. Is there data in this, you know, patients this old, this young?
Yep.
Any data at all that this myocardial work? I presume for global work index and all that might be different from for adults, but certainly global work efficiency might be useful.
Yeah. You know that started 2 years ago, I started to join some research about the myocardial work in pediatric ones. And also recently we have got some systematic review due to the VGOS and also the myocardial work in the pediatric population. And with this normal range I write out here is also compared with age and the gender of the patient due to the GOS and also the normal range of the efficiency and the weight compared with the age here. And I hope that not only the adult, the pediatric population, we also apply some new techniques in echocardiography to diagnosis first, and after that the follow-up for them and get the good result at the first time we making the treatment.
Very one question from the audience. Is the father started on sacubitril valsartan for dilated cardiomyopathy as well, or because liver 50%? Do you know this?
Yeah. Yes. About the treatment for this baby, so far I've just used the diuretic and also the ACE inhibitor because of her age, her weight, and the other FDA approved so far is sacubitril valsartan. It just indicated for the patient more than 12 months old. And that's the reason why so far I'm just use the diuretic and also the ACE inhibitor for this patient.
Thank you. Dr. Magno, would you like to answer?
Oh, okay. Actually, there are more questions coming in from the very active audience. There's a question from Jason Tan, and I think that was addressed already. Another question from Dr. Brian Ramirez. Can we use myocardial work in monitoring treatment response and in predicting outcomes for cardiac events or prognostication?
Yeah. Yeah.
Okay.
Thank you for
answer. You have answered it. Okay, we can.
May I have a question?
Yes, why?
Yeah, I would like to ask about technical issues. Is there any difficulty in doing strain and myocardial work in the newborn baby, especially when the heart rate is very fast? What is the optimum frame rate do you use?
Yeah. Also, as the recommend from the fast heart rate in pediatric one, when we do the GOS for patient, the strain for patient, the frame rate is at least 40, and maybe with compare with the 160, the frame rate I also add for the infant, maybe for the pediatric one with the problem due to the cardiomyopathy, not only the dilated but also the hypertrophy cardiomyopathy. We also use the cardiac MRI, but this one they need the GA and also very difficult because control with the heart rate like this. So far in Vietnam we cannot use the cardiac MRI for this infant.
Just a follow-up question. How are you going to counsel the parents? Because the parents are quite young, and if they want to have another child, how are you going to
Yes.
counsel the parents?
Yeah. After receiving this Sanger test from the father and the mother, you can see here very difficult to explain for them because they also got the gene for the cardiomyopathy. But I need to go back for the phonetic problem of the father with dilated mind under the borderline dilated LV and the preserved LV function with the negative exercise echocardiography and others not remarkable. So I need to consult with them about the poor prognosis of the baby. Maybe it's a combination of gene cause. It may got the severely one. And the father, so far he got one of the gene and also the preserved LV function. I cannot find out the other cause. And so sorry because their financial problem. So far the father haven't got the cardiac MRI result yet, and the mother also follow up. The other sister, the older sister, I also advise them to bring the patient to coming for checkup the echocardiography and also the genetic testing. And maybe next to 1 to 2 years, 1 to 2 months, they will bring the baby from the rural to the hospital for checkup.
There is one question from the audience, Dr. Thuy. What is the EPRIM to diagnose diastolic dysfunction in infant? Is there Z-score?
Yes, they got the Z-score in the Boston Z-score for all of the characteristic of the echocardiography. But so sorry, in this case, I haven't mentioned. It's about with this patient, I write down is here is due to the 3 characteristic in the low EF patient. And I just write out the E/8 and E prime and the LV volume index, and also the other is the PA pressure. In this case, I have no the PA systolic pressure at the first time. Maybe I lost the information or something. Very difficult to test the TR. So I have no image here. And also I use the PA mean pressure for replacement. And
Okay.
you can yeah.
Sorry. You continue, sorry.
Yeah.
Continue your answer.
Yeah, in the pediatric one, very easy to assign into the Z-score parameter for all of the Z-score. And also for the Boston Children's Hospital, we have got the Z-score free there when we admit the gender, the age, and the kilo height of the patient.
I think that is the last question. It's difficult to understand. What is the difference of the stroke person to the normal person? Do you understand this question, Dr. Thuy?
Yeah, the stroke patient. Yeah, I don't know.
To the normal person, different of what? I don't understand. Okay, any comment from the panelists?
Dr. Thuy, I mean, it's not easy to get genetic studies in all babies. So if your colleagues could not do genetic studies, how would you approach this patient?
I approach the patient from the routine test first, taking examination. If the others I saw in the first slide for taking examination for patient to help us to include something like the muscle tone, like the dysmorphic or the normal pose in the forelimbs. And after that, with the chest X-ray and the ECG, we can make the primary diagnosis, maybe suspected the dilated cardiomyopathy. And with the echocardiography, with many features, we need to exclude some congenital heart disease, some structure like the structural heart disease, like the coarctation or the abnormal of the coronary abnormality. So after many things like this, firstly with this case, I also making the diagnosis with the baby is so early age with the dilated LV, Z-score more than +2 and severe LV dysfunction, systolic dysfunction. And at first time, at the other, if I have no any genetic testing, I also making the diagnosis, the patient with the idiopathic primary, one of the primary dilated cardiomyopathy. And also the treatment for this kind of patient in the early age is also the heart failure treatment and control the symptom for the patient. If they have no any evidence for genetic testing, also we make the also got the poor prognosis like the other, because the cause is cannot reversible.
Okay, thank you, Dr. Thuy. You have an excellent case. Thanks for the panelists for the question and for the audience. Now we move to
can
the
I just a quick question to Barakat. Barakat, what were you thinking of?
I think the fact is in a lot of places we don't have genetic studies, so
Yes.
the workup here, you need to look for the vaccination status, whether there was any infection during pregnancy and etc. All this needs to be ruled out because in order for you to diagnose idiopathic dilated cardiomyopathy, you have to make sure that you have ruled out everything else, and that is probably what I would like to highlight to other those attendees here, because not every center will have capabilities to do genetic studies, especially in the rural area. So what you can do is you need to exclude other causes. And that is very, very important. And especially vaccination status is extremely important. And whether there was any infection during pregnancy and etc., viral infections, those things needs to be really looked at before we diagnose these patients as familial dilated cardiomyopathy.
I agree with Barakat. In dilated cardiomyopathy, we need to diagnose it, elimination.
Yeah.
Okay, Univ, for the third talk, we have no more time. I would like to invite Dr. Minh Thư for your talk. Minh Thư, did you open my microphone?
Good evening, everybody. Today I would like to present a case with hypertrophic cardiomyopathy. This is a 53 years old man. He is Vietnamese. His occupation is a monk. He presented in our hospital. He suffered from shortness of breath when he walked 1 kilometer. The symptom becomes rules. At present, he has shortness of breath with 100 meter walking. He has no auto dyspnea. Physical examination show he alert. BMI is 20 kilogram per square meter. Vital sign is normal range. Regular heart rate, a systolic murmur at the lower left sternal border with a decrescendo pattern. No pulmonary rale or motor structure in basal lungs. Abdomen is tenderness. No edema. Left and right ABI is 1. Lab that show normal of hemoglobin and normal white blood cell and anti-protein B is 850 picogram per milliliter and normal serum creatinine and normal TSH. Genetic testing detected a pathogenic mutation in MYS7 genes. Chest ratio normal, cardiothoracic ratio and pulmonary vascularity is normal. ECG show biatrial hypertrophy, biventricular hypertrophy. Hunter ECG reveals synovium, atrial premature contraction, and normal coronary artery is in cardiac MSCT. Echocardiography show in the left heart there is eccentric left ventricular hypertrophy, good LVEF, but decreased LVGUS minus 13%, and hypertrophy of interventricular septum, dilated left atrium, presented. Maximal gradient trans-alveoli is elevated. Hypokinesia of interventricular septum. In right heart, the dimension of right ventricle and right atrium is normal. The free wall thickness is 6 mm. These are some images of echocardiography. We can see the image A and B show the maximum and the absolute interventricular septum thickness is 27 mm. And the image C and D, we can see the morphology in the patient is the reserved septal curvature. The video A and B show the turbulent flow in LVOT and measure the maximal LVOT gradient is 80 mmHg. So the patient have left ventricular outflow tract obstruction. In for chamber view, we measure lab V of 64 milliliter per square meter and the ratio EA1 and E apostrophe 13. Tricuspid dilatation velocity is 2.7 meters per second. So the patient had grade 1 diastolic dysfunction. By using Simpson method and 3D volume measurement, we calculate the LVEF is 62%. By using strength, we evaluate the systolic function in the patient. The degree of LVGUS here is minus 13%. In summary, this is the patient 53 years old. She had dyspnea on induction with NYSH3. She had obstructive hypertrophic cardiomyopathy with maximal LVOT gradient 60 mmHg and the IVSD 27 mm, LA 48 mm with LVEF. So we calculate sudden cardiac death at 5 years according to ESC guideline of 3.2%. So the patient belonging to the low risk group. In the patient The patient have to decrease the gradient plus LVOT to improve his symptom. So we indicate alcohol symptom ablation for the patient. After procedure, the NYSA decreased to 1 and maximal LVOT gradient down to 33 mmHg. If we have the left ventricular hypertrophy in echocardiography, we have to think about the other disease besides HCM. For example, amyloidosis, hypertension, Fabry disease. In amyloidosis, we can based on the strength with the reflux cherry on top in my here to suggest cardiac amyloidosis. In hypertension, we can see here the hypokinesia of that ventricle septum, and we can realize the Fabry disease may show the hypokinesia of a lot of segments. In HCM, morphology associated with complication. The video A, this is the patient in the presentation here. The patient had preserved septal curvature morphology. It usually causes LVOT obstruction. Meanwhile, the patient had mid-ventricular hypertrophy. It usually leads to mid-ventricular obstruction and leading to apical aneurysm. We can see aneurysm here. Sigmoid morphology can cause LVOT obstruction. There are two third patients with HCM who has LVOT obstruction. One third case had LVOT obstruction occur at rest. One third case had LVOT obstruction occur with maneuver or provocation. In the patient at rest, the maximal LVOT gradient is 21 mmHg. After Valsalva maneuver, we can see the maximal LVOT gradient elevated to 58 mmHg. Sometimes we indicate CMR for HCM patient. In case we cannot measure exactly the aquatic head in echocardiography, especially in the patient. Especially in the patient with HCM, CMR can evaluate the extension of legate. In the patient, the legate is 49 grams, about 15% of LV myocardium. This is a risk factor of sudden cardiac death in HCM patient. In conclusion, I emphasize some point. Echocardiography is important in diagnosis, treatment, strict stratification for sudden cardiac death in hypertrophic cardiomyopathy. Exact assessment of LVOT obstruction, diastolic and systolic function, and right measurement left ventricular thickness are necessary. Thank you for your attention.
Okay, thank you, Dr. Tu. Very interesting case. I think that HCM is not a rare disease. The frequency is high. Now I would like to ask some opinion, some comment of Dr. Barakat from Malaysia.
Obstruction, Doppler wave, and a mitral regurgitation wave.
Okay, Dr. Tu, can you answer it?
Yes. If the we can differentiate the the apex. Sometimes the patient had LVOT and obstruction and mitral regurgitation, especially in severe MR. We can use continued weight in LVOT. At that time, we have the tube flow, MR flow, and LVOT flow. So LVOT is after the MR flow, and we realize the shape of LVOT is different from the MR flow.
Any other comment, Dr. Barakat?
Yeah, so the shape tend to be like a sail-like because of the dynamic obstruction compared to the mitral regurg, which tends to be more parabolic. But sometimes it's still very difficult to differentiate both. And I think as for sonographers, it's extremely important where you are slicing across, especially when you are dealing with both mitral regurg and LVOT Doppler. The other question that I wanted to ask is, your case, there was apical sparing. So, I mean, when you did strain on your case, so this is one of the differentials when you get apical sparing in a LVH, yeah. So, but in this case, I think it was quite clear there was SAM and etc. So, is there any other causes of SAM besides in the setting of hypertrophic cardiomyopathy?
You understand the question, Dr. Thơ?
I'm not clear.
Can you repeat?
Yeah, so systolic anterior motion of the mitral valve that occurs that causes the LVOT obstruction. Are there any other causes of SAM besides in the setting of hypertrophic cardiomyopathy?
Systolic anterior motion you can meet in another disease, Dr. Thơ?
Yeah, the cause of the cause of SAM is due to the obstruction of LVOT. I think any cause of the obstruction of LVOT, for example, in Fabry disease or even in amyloidosis, with the obstruction complication in LVOT can cause SAM.
Okay. Dr. Lim, you frequently meet HAM in your country?
Yes. Thank you. It's a very interesting case.
Yeah.
I just have one question. Because you have mentioned in your case about the risk of cardiac sudden death. I want to know how do you stratify the patient risk for sudden cardiac death based on echocardiography finding?
You understand question too?
Echocardiography.
We have score to count on sudden cardiac death.
Yes, we are based on ECD guideline or ACC guideline. Risk factor for sudden cardiac death in HCM conclude non-sustainability, age, the family history of sudden cardiac death. So we other criteria we can found in echocardiography, for example, the dimension of left atrium, the gradient transalveoli, and LVEF. In addition, the legged extension in cardiac MRI. So I think the echocardiography can supply 5 risk factors among 10 criteria for for estimate the risk of sudden cardiac death in HCM patients?
I can address that in the case of HCM with apical aneurysm, it's a criteria for sudden cardiac death. In this case, we need to put ICD. And the second thing, when the interventricular septum and the thickness of the septum about 30 millimeter is one criteria we think about sudden cardiac. And the third thing, you can have an app in the to count on so many factors to think about. When the sudden cardiac is about 5%, we need to put ICD for the patient. Any question from the panelists? Dr. Lin, do you have anything?
Yeah, just to make a point that, we always think about the timing of mitral regurgitation to differentiate it from LVOT obstruction. The usual thinking is that with MR, it occupies the isovolemic contraction time, so it starts a little bit earlier, but not in all cases, and certainly when MR is due to SAM and it's so-called obligatory mitral regurgitation from SAM, MR can start exactly at the same time as LVOT obstruction because it happens only because of the SAM. So that seems to be the only situation where MR starts at the same time as the LVOT obstruction. The second thing was I found one of your Doppler images quite interesting. Maybe you can go back to your slides.
Dr. Thơ, can you go back to the slide?
If you can go back to your slides, go backwards to the, I think it was the Valsalva maneuver, that slide.
Dr. Thơ, can you return to your slide?
Yeah, go backwards, huh?
Go back.
Yeah, I think to the slide where you showed the Valsalva maneuver and the LVOT obstruction. Back. Yes, this one, I think. Maybe back one more.
Go back one more too. Okay.
One more. Some more.
One more too.
Okay, no, then it's forward. Well, yeah, go forward. Yeah, this one. So you notice that you're in the Valsalva, on the right side, there, and you are sort of like you have a late peaking flow velocity curves, but there are two late peaking flow velocity curves.
Yeah.
Superimposed on each other. What do you think is the second one? The first one, I think, is the LVOT obstruction. Is that correct?
The first one, yes.
What's the cause? What about the second one?
Yes.
You know what I mean?
The first one, what do you think too?
Yes, the first one, I think is the
LVOT after Valsalva maneuver. No,
Yeah.
so the first.
Yeah, so on the right side, you can see during the
Right side.
Valsalva, you can see that there are two flow velocity curves.
That's
One is
right.
about 5 meters per second. The first one is 5 meters, and the second one is a little bit less, about 4 meters. What's that second?
Do you think there is any difference between the two images? One belongs to left outer tract, one belongs to MR.
Yes, I think when we LVOT obstruction, LVOT flow.
Okay.
Yeah.
So you think the first one is MR and the second one is LVOT?
Yeah. Yeah. It's belonging to MR flow and LVOT flow.
Okay.
LVOT flow. Yes, the shape of LVOT obstruction.
Yes,
Within
agree.
the shape. Yeah.
Yes, the shape. Yeah, the shape here. You see the.
Okay, we have a question from the audience. The JRS pattern appear to have relative apical sparing. Should work up for cardiac amyloidosis be done in this case? Question, Dr. Thư.
In the this.
Can you show the slide of strength?
According to the presentation of Dr. Hoài, so the Dr. Hoài mentioned the question, the specific of cherry on top. Cherry on top image has the specific about 87%. So I think the cherry on top can present in some other disease besides amyloidosis. So in the patient, we don't think about amyloidosis, although the image look like cherry on top. So the first clinical scenario in the patient is has no the congestive heart failure like the patient in the presentation of Dr. Hoài is the belonging to the cardiac amyloidosis. In addition, the patient has no some symptom or sign belonging to the congestive heart failure, elevated jugular and hepatomegaly and edema in lab, and the normal range in lab test, anti-globin B, and it's not high, and especially in the ECG, we can see the biventricular hypertrophy, not low voltage in ECG like the patient in the presentation of Dr. Hoài. In addition, in the patient, we can see the dimension of interventricular septum 27. Meanwhile, the posterior wall is 12 mm. In cardiac amyloidosis, we have concentric hypertrophy of left ventricle. In addition, in our patient, we have no restrictive pattern. We can see here, the ratio EA is 1 and EE 13. In cardiac amyloidosis, we have in the patient of the presentation of Dr. Hoài, the ratio EA 5.5 and the ratio E apostrophe 33. So the patient here have no the restrictive pattern.
In the American guideline, sometimes we need cardiac magnetic resonance, MRI, to differentiate between amyloidosis and hypertrophic cardiomyopathy and constrictive pericarditis. So
Yeah.
sometimes we need MRI to differentiate.
Yes, yes.
Okay, I think that we still have some question, but we have not enough time for the question. So I think that if you have any question, you can contact with our team by email. We will show by email for the speaker for you if you would like to ask for question. So now I would like to invite Amelia Suzento for your closing remark.
Okay, thank you so much. Thank you, Prof. Pham. And I'd like to congratulate all of you for this interesting evening. Very nice and very interesting cases. We learned a lot and very fruitful discussion. And for that, I'd like to thank Dr. Huai, Prof. Pham for organizing this evening. And also I'd like to thank the other presenters, case presenters, Dr. Tu, Dr. Tui, and of course, our panelists, Prof. Ling, Dr. Barakat, and Dr. Lim. And also, I'd like to thank GE Healthcare for supporting this event. And in this opportunity, I also would like to invite all of you to join our next ASEAN Echo Dialogue in May. And it will be collaborated by Asia Pacific Association of Echocardiography and ASEAN Echo, and the host will be from Indonesian Society of Echocardiography, and we are going to discuss about the role of echocardiography in interventional echocardiography in congenital heart disease. So don't forget to join us in May. And once again, congratulations to all of you, and thank you so much for all the audience who joined together in this nice evening. Bye-bye, keep in touch, and have a nice evening. Thank you.
Thank you so much.
Bye-bye.
Bye, everyone.
Thank you.
Thank you. Bye.